Hi everyone, and welcome to our weekly podcast brought to you by VJOncology. In this week's episode, we'll be covering the latest updates in ctDNA-guided surveillance and treatment monitoring in breast cancer. To begin, with Wolfgang Janni from the University of Ulm in Germany, who discusses the SURVIVE study, which investigated overall survival in the standard care surveillance compared to intensified surveillance using liquid biopsy.
Well, the SURVIVE study is basically addressing the question which has been asked 30 years ago, being addressed by two large Italian prospective randomized studies comparing intensified surveillance versus standard surveillance in early breast cancer survivors. And what the Italian colleagues did 30 years ago, they did imaging like chest X-ray, liver ultrasound, but also tumor marker testing. And they actually did find asymptomatic distant metastases earlier in the experimental arm. However, that did not lead to overall survival benefit. Now, we are convinced that obviously in 30 years, there has been dramatic change in the treatment landscape of early breast cancer. So this is one reason to address this question again. And the second reason is that now we have better and much more sensitive, ultra-sensitive methods to detect persistent disease by ctDNA. And this is exactly what we do in the SURVIVE study. It's a prospective double-blind phase 3 study randomizing patients with intermediate to high-risk early breast cancer between standard of care surveillance versus intensified surveillance using liquid biopsy. And within that liquid biopsy, we look at ctDNA, conventional tumor markers, and also circulating tumor cells. Patients with any finding in peripheral blood will then undergo imaging. Patients with distant metastasis, of course, get standard of care. Patients with molecular relapse only are then candidates for treatment intervention trials. We offer 2 treatment intervention trials, the European EORTC Treat ctDNA study, randomizing elacestrant, oral SERD versus standard of care. And we also have the SURVIVE HERO study, which probably will start end of this month in late March 2025, with first patient in randomizing trastuzumab deruxtecan versus standard of care in patients with HER2-positive, HER2-low disease.
He also comments on additional trials monitoring molecular relapse using ctDNA and how patients who display no distant metastasis are candidates for early monitoring trials.
Now, if we talk about the SURVIVE study, which is a surveillance study in early breast cancer survivors, in which we randomize patients between standard of care surveillance versus intensified surveillance using liquid biopsy, including ctDNA testing, then we really have to look for overall survival. Because if we detect asymptomatic distant metastasis earlier going through liquid biopsy, then of course we shorten disease-free survival and distance disease-free survival with the goal of gaining on overall survival. Now, the vast majority of studies beyond that are focusing on patients with true molecular relapse. Molecular relapse defined as patients with molecular disease, ctDNA in peripheral blood, derived from either tumor-informed or tumor-agnostic tests, and then patients without metastasis at that time point. Now, depending on the test, depending on the timing, there is a certain percentage of patients who already have asymptomatic distant metastatic disease at that point of time, and they, of course, get standard care of treatment. Those patients who do not have any overt distant metastases on imaging, they are candidates for interventional trials, which were discussed yesterday. And in these trials, we probably can use IDFS and distant disease-free survival, as in most early breast cancer trials, or ctDNA clearance. Since we have a parameter which is ctDNA positivity or molecular relapse, this is also an instrument for monitoring.
Next up, Arielle Medford from the Massachusetts General Cancer Center in Boston shares findings from the LEADER trial, a phase 2 trial that evaluated the impact of adding ribociclib to adjuvant endocrine therapy in patients with ER-positive, HER2-negative early breast cancer with detectable ctDNA after surgery.
The LEADER study was one of the first molecular residual disease-guided therapeutic interventions in early breast cancer. MRD is molecular residual disease. It's something that we're only recently able to detect because of these novel assays that can detect very low levels of circulating tumor DNA. And what we know is that if you detect ctDNA, circulating tumor DNA, in patients that have otherwise undergone curative intent therapy, the chance of the cancer coming back is incredibly high. And so the design of the LEADER trial was asking, well, if we escalate therapy in the setting of detectable MRD, can we change patient outcomes? And so patients who had completed curative intent therapy for estrogen receptor positive HER2-negative breast cancer, who subsequently had detectable molecular residual disease on endocrine therapy, we added the CDK4/6 inhibitor ribociclib, and after the first year measured the level of ctDNA change and clearance. And that was the initial endpoint, and then patient outcomes being the follow-up endpoint for the LEADER study. So the LEADER trial, what we ended up identifying was that using this initial whole exome sequencing-based MRD assay, we identified roughly 11% of patients had detectable ctDNA. And then importantly, when looking at scans, it is important to distinguish, we identified 4 patients that also had metastatic recurrence. So those are a separate treatment pathway from true MRD. And then for the patients that we then enrolled onto the study and gave ribociclib, we found that patients that had lower levels of baseline ctDNA were more likely to experience clearance. An ongoing question is how much of that is drug versus limitations of the assay itself. With these new refined assays, I'm looking forward to reapplying this with these more sensitive assays to understand clearance versus decrease. But regardless, if a patient experienced a decrease or clearance, they had a much longer distant recurrence-free survival compared to patients that didn't. We're talking 1.5 years versus less than half a year in terms of time to distant recurrence. So really looking forward to expanding, learning from that study, and then applying it to future MRD-based interventional studies.
Following on, Seth Wander from Massachusetts General Hospital discusses exploratory ctDNA marker analysis from a phase 1/2 study of vepdegestrant in ER-positive, HER2-negative advanced breast cancer.
We've been excited to be working on the development of vepdegestrant, which is the first PROTAC, that's a proteolysis targeting chimera. This is an interesting new type of anti-estrogen molecule that binds to the estrogen receptor and actually recruits the ubiquitin ligase machinery of the cancer cell to come and more fully degrade the ER. Here, we were presenting some updated biomarker analysis from some of the preliminary work predating the phase 3 VERITAC-2 study. We explore the spectrum of different ESR1 alterations that are present in this cohort, and we demonstrate dynamic changes on ESR1 as a function of total allelic fraction within the cells, showing that patients who have deeper drops in ESR1 better sort of target engagement with the molecule, also potentially demonstrate better response, even in this more heavily pretreated early phase population. As I mentioned, this was a multi-center open-label study with a dose escalation component in patients with ER-positive, HER2-negative metastatic breast cancer. We had 154 patients treated with vepdegestrant, the vast majority of whom had available ctDNA samples for analysis, nearly 140 of these patients. We explored the landscape of ESR1 alterations. The most common type of ESR1 alteration, not surprisingly here, was the D538G variant, with other common alterations in Y537 and E380. We looked at a number of different factors in an effort to determine if there was any predictive component for how well patients were going to do based on their ESR1 alteration. What we noticed was that the ESR1 variant allele fraction or overall tumor fraction at baseline were not directly associated with clinical benefit rate. However, when we created a ratio normalizing the ESR1 variant allele fraction to the overall tumor fraction, patients who had higher ESR1 variant to total ratio did end up having better clinical benefit. And that makes sense. It means across the mutational spectrum of the cancer, those patients who had higher proportion of ESR1 alteration relative to the total tumor fraction detected got more benefit from the oral SERD. And that was of interest to us. in thinking about different ways to help predict which patients may be optimal candidates for this type of approach, either with vepdegestrant or with other emerging next-generation anti-estrogen monotherapy or potentially doublet therapy regimens.
He additionally comments on the emerging role of ctDNA analysis in monitoring treatment response and predicting resistance in breast cancer.
I think this is going to emerge as a very standard approach for us, particularly on the heels of the SERENA-6 trial. In contemporary or recent clinical practice, most people would look at ctDNA at the time of clinical or radiographic progression. But I think we're learning more and more about how valuable ctDNA dynamics can be, even for patients actively on treatment. Now, that could be comparing a baseline ctDNA to 1 to 2 cycles in to see how well we're engaging with the target. For example, dynamic drops in ESR1. For patients who have this type of breast cancer, or it can be the reverse. Patients who are doing well on therapy and we're watching over time for the emergence of alterations like ESR1 to predict when we should change therapy, for example, like in the SERENA-6 study. I think your question is a very important and practical one. We don't yet have a lot of experience in clinic doing circulating tumor DNA analysis on treatment in the absence of clinical or radiographic progression. That's going to require some changes to the guidelines. It's going to require in the US and abroad some changes in the way, for example, that insurance might cover this kind of testing. But I think on a translational scientific side of things, we're demonstrating the value in looking at these dynamic changes, both to map tumor response or to predict which patients, like we were just discussing, might have the best tumor response, but also to predict the emergence of resistance before patients develop symptoms or develop radiographic or clinical changes. So I think we have more work to do. I hope that we're going to be able to get there and that we're going to see a paradigm shift in the way we think about ctDNA as not just a tool for treatment selection at progression or at new development of symptoms, but as a monitoring tool to look at on-treatment effect or emergence of resistance.
Finally, Rinath Jeselsohn from Dana-Farber Cancer Institute in Boston discusses findings from the PACE trial, which analysed the ctDNA dynamics in patients with HR-positive, HER2-negative metastatic breast cancer progressing on endocrine therapy plus CDK4/6 inhibition.
So the phase 2 PACE trial was a study in which patients who have hormone receptor positive advanced breast cancer who had at least 6 months of treatment with palbociclib and an aromatase inhibitor were then randomized to 3 arms, including fulvestrant alone, fulvestrant plus palbociclib, or fulvestrant plus palbociclib and the PD-L1 inhibitor avelumab. The trial, when looking at the fulvestrant versus fulvestrant palbociclib arms, the trial did not show added benefit of continuing palbociclib in this setting. The trial did show a numerical improvement when adding avelumab to the combination of palbociclib and fulvestrant. In this study, we analyzed the circulating tumor DNA that was collected as part of this clinical trial, and ctDNA was collected at baseline from 200 patients on this trial. And we focused on the arms of the fulvestrant and the fulvestrant plus palbociclib to understand what are the genetic alterations identified through ctDNA that are associated with progression-free survival in second-line endocrine therapy-based treatments. So first off, when we looked at the baseline samples of the 200 patients, so again, these are patients that have all progressed on a CDK4/6 inhibitor plus palbociclib, but were on first-line treatment with this combination regimen for a reasonable period of time of at least 6 months. And what we found was that the most common genetic alteration or mutation in this patient population were the ligand-binding domain mutations in ESR1, which were found in more than 50% of patients. The second most common mutation was mutations in P53, followed by mutations in PIK3CA and GATA3 mutations and RB1 mutations. Interestingly, in this patient population, we found RB1 mutations in 10% of the patients, which is slightly higher than what has been reported previously in a similar patient population. When we looked at what are the associations between these mutations and progression-free survival, what we saw was that clearly RB1 mutations are associated with poor progression-free survival with a second-line endocrine therapy or endocrine therapy plus palbociclib, and progression-free survival with these regimens in patients who have an RB1 mutation was less than 2 months. We also found that P53 mutations, PIK3CA mutations were associated with decreased progression-free survival in this setting. And when we looked at the ESR1 mutations, we found that if we look at all ESR1 mutations, there was no significant association with progression-free survival on endocrine therapy-based treatment. However, when we look specifically at the Y537S mutation, which we and other groups have shown to have more robust phenotypes, we did see that the presence of a Y537S mutation was associated with worse progression-free survival in this setting. So in summary, we were able to present here in this study the genomic landscape of patients post a CDK4/6 inhibitor plus endocrine therapy. And we also identified specific mutations that are associated with outcomes in this setting, which could help direct future treatments in the setting of second-line treatment of metastatic hormone receptor positive breast cancer.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.